Hello, this is Dr. Bhomik, and those who are following my lecture already know that I'm a retired professor of pediatrics, University of South Alabama College of Medicine, and also retired colonel from U.S. Air Force. And I am a board certified pediatric endocrinologist. And today I'm going to talk about thyroid problem in children and adolescent. Those who are following my lecture, you already know that I have talked about neonatal thyrotoxicosis, congenital hypothyroidism, but this time I'm going to give lecture on thyroid divided in three parts. And I believe, and some of you suggested that to keep the lecture shorter. So in order to do that, I have decided to give this lecture in three parts and try to limit it for about half an hour. So today we are going to discuss about neck mass. Now this is a lecture which will cover some of the anatomy, the physiology, and the common clinical finding that each and every pediatrician, nurse practitioner, family practitioner has faced in day-to-day in their practice. So confronted with a problem of neck mass, and I'm talking more about the anterior neck mass or midline neck mass, these are the following questions that should be asked. First should be that how long? What is the duration? How long this neck mass has been observed? Secondly, that is it associated with fever, swelling, or pain, which obviously would suggest a inflammatory origin. And did it come after an acute illness or trauma? Has it changed size a lot over the period of time, or it has been stable? So is there any changes in size, significant changes in size? Any history of exposure to radiation or goiterogenic substance, some medicine and some food? And above all, also very important to know, is there any family history of thyroid disease? So first of all, just to shortcut on this issue is that obviously we have got to do the physical examination. Is very important. Location of the mass, is it midline or it is lateral side of the midline, and is it just below the mandible, or it is just like where you mostly see the thyroid gland. Mobility of the mass is very important, especially does it move with deglutition or swallowing. A mass arising from thyroid gland will move with the will move up and down with the swallowing. Then as you examine and make sure you feel the consistency of the mass, is it irregular surface, is it smooth, is it firm, or is there any fluctuation or any nodule that you can specifically feel? Beside thyroid enlargement, do you feel any nodule? And clinically, do you see any evidence or clinical symptomatology or sign of either hypo or hyperparathyroidism? So when you talk about the goiter or thyromegaly, it could be because of the stimulation. That is, it is either stimulated by excessive TSH, thyroid stimulating hormone, or an antibody that stimulating the thyroid gland, or it could be inflammatory. It could be subacute thyroiditis, or it could be bacterial thyroiditis, which is extremely rare. And does this patient live in iodine deficiency area like in Himalayas, Andes, where the soils are poor with iodine? Then what is the definition of thyromegaly or goiter? That if we in general, if we discuss thyromegaly, the people will say that enlargement of thyroid gland 2 times of the normal, 2 times or greater than it is thyromegaly. World Health Organization defined goiter interestingly as an enlargement of the lateral lobe of thyroid that exceed the size of a terminal phalanx of the thumb of the patient. The enlargement is terminal phalanx of the thumb of the given patient. And so whatever is the definition, you should be able to see it. That's the main thing, that you can see the swelling of the neck. An incident is about 1 to 3% of the school children and adolescent may have goiter without any thyroid problem, just may have goiter. And this patient, as I have mentioned, could be euthyroid, could be hypothyroid or hyperthyroid. So if one need to classify the goiter, then we can classify the goiter in 3 ways. One is diffuse goiter or generalized enlargement of thyroid gland. Another is nodular goiter, which is very rare in children, but is common in adult medicine. Nodular goiter, or is it cystic? And that can be palpated by a experienced clinician. But sometimes cystic, there may be so much fluid inside the cyst, it might feel like solid. And so this is something just in general I am talking about, but it is not easy to make all these delineation just by physical examination. So say for example, if we found a diffuse goiter, then what could be the differential diagnosis? What are the etiology of a diffuse goiter? So in general, the first thing that we would think about autoimmune thyroiditis, which is also known as Hashimoto thyroiditis. So autoimmune thyroiditis could be the first thing that should come in your mind. And then there could be hyperthyroidism secondary to what we call Graves' disease. And there will be a separate lecture on autoimmune thyroiditis, and there will be another separate lecture on Graves' disease. And also you can see a very big goiter if the patient is living in iodine deficiency or insufficiency area, either in the food or the location, as I said, is the Himalayas or Andes mountain, where the soils are very poor with iodine. And then there could be problem with thyroid hormone synthesis, or the enzyme necessary for the formation of thyroid hormone is not there. And the most common was this thyroid peroxidase, TPO, thyroid peroxidase. So continue with the diffuse goiter. Very rare, extremely rare is TSI is producing pituitary adenoma or microadenoma. Thyroid hormone resistance syndrome, where thyroid gland has to work pretty hard to overcome that resistance, and that is something is also very rare. Is there any goiterogenic substance or antithyroid drug that patient has been taking? Inflammatory will be acute or subacute thyroiditis, or it could be a idiopathic one, is simple colloid goiter, and that appears in the adolescent, and sometime all the tests will be negative including the antibodies, and it could be pretty big, and I'll talk a little bit more about that when you talk about Hashimoto's thyroiditis. The nodular goiter could be benign tumor or the cyst. It could be non-functioning cold adenomas, and that's called cold nodule. And as you have learned, or you have learned in your uh, uh, physiology class and anatomy, that a cold nodules is something you don't like to see. Cold nodule, unless when otherwise, it could be a malignant tumor. On the hot nodule, it could be a toxic hot nodule, usually not a malignancy. And autoimmune thyroiditis is the master of disguise. It can present in any form. It could be generalized, it could be uh, localized in one area, fibrotic area, or it could be even cystic in certain area. So therefore, the autoimmune thyroiditis will remain in the differential diagnosis for any goiter. It should remain in the differential diagnosis for any goiter. Just to remind you very quickly that if you see a goiter in the neonate or in infancy, the first thing should come in your mind is this patient is hypothyroid. And if it is so or not so, then is it an enzyme deficiency or what we call dyshormonogenesis. And most common enzyme deficiency is thyroid peroxidase, that I have mentioned before. And if the mother is taking antithyroid medication and they do crosses the placenta, both PTU and tapazole or methimazole crosses the placenta and therefore may produce goiter in babies. And then this could be a neonatal Graves' disease, rare, and the iodine deficiency in the endemic area. So although this is not a baby, but that this could show that here is that not generalized enlargement, looks like at one thigh it is more prominent, is right here. So you see this kind of thing. Either this is goiter and the rest of the thyroid may be fibrotic. So, but this is something you can also see. So, iodine deficiency goiter is the number one cause of the goiter or thyromegaly in world. Very important. Read the question carefully. The most common cause of goiter in the world is iodine deficiency. Not your Hashimoto's thyroiditis or Graves' disease, iodine deficiency. And the thyromegaly in iodine deficient area is a very big, huge thyromegaly. And those who follow the National Geographic Channel in certain part of Africa and Asia, you can see the ladies with humongous thyroid gland. And they live in iodine insufficient area. And as I'm telling, my next slide is the area of mountainous region like Alps, Andes, and sub-Himalayas. And in a country where the food and water is not supplemented with iodine and salt also not supplemented with iodine, you can get the iodine deficiency. This one is, look at that, how this goiter looks like it has been going up to that humongous goiter. And this picture was telling one area of Thailand. And I have got that one from one of the magazine. Very big, humongous goiter. And this patient had iodine deficiency. So therefore, the goiter is something that alert you that there is more than likely a thyroid disease. But what it does not alert you about the cause of the goiter, and there are various causes of the goiter, and the one that I'm going to say at the end is now, and I'm going to say that sometime obesity, when the kids are really obese, morbidly obese, and they have got neck swelling, and that goes from one side to another side, more or less through the circumference of the anterior neck. Now that it is tough sometimes to differentiate that one, whether this is a pad of fat under the platysma muscle or it is thyromegaly. In fact, a experienced clinician has also sometimes have hard time to differentiate. In general, that if it is arising from thyroid gland versus if it is a pad of fat, the most of the time, if you tell the patient to turn the head on the opposite side, you will see the anterior border of the stenomastoid muscle. If it is a thyromegaly, your anterior border of the sternocleidomastoid may be obliterated. But I tell you, it is still sometimes very difficult, and the people may have to get the help of thyroid sonogram. So I'm going to finish this discussion by showing you the picture of a great man, Dr. Hashimoto's, and I think that in my other lecture I will bring all the great people, those who have contributed so much in our understanding of thyroid disease. So thank you, and the next lecture will be on Dr. Hashimoto's discovering Hashimoto thyroiditis, and we'll talk a little bit more about him a little bit at that time.